Welcome, everyone, to vpod.ai. We're here to take stacks of sources and really distill them down into the key nuggets of knowledge for you. Think of it as your shortcut to being well-informed. Today, we're doing a deep dive into Hurthle Cell Carcinoma. Now, this is a pretty challenging and quite rare form of thyroid cancer. It needs a very specialized approach, for diagnosis and treatment. Our mission today, to
Hmm.
really unpack what makes it so unique, we'll look at everything from its microscopic identity right down to the cutting-edge genetics that are starting to shape how it's managed. Before we jump in, though, just a quick note that this deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged solutions like VMware, Hyper-V, Proxmox clusters, AI servers, even the SA365 turnkey security appliance, plus public and private cloud. You can check out stonefly.com for more info.
And it really is fascinating, how much research has uncovered about this specific type of cancer. It truly stands apart from other thyroid malignancies, and understanding those differences, well, it's absolutely critical for patients facing this.
Okay, let's unpack this then. What exactly are these Hurthle cells, and what makes them the foundation for this particular type of cancer?
Right. So Hurthle cells, sometimes called oxyphilic cells, or historically even Ashkenazi cells, though that's a bit of a misnomer. Ashkenazi actually described them first, not Hurthle. They're a unique kind of thyroid follicular cell. What really makes them stand out is how they look under the microscope. They're big polygonal cells, very distinct borders, and they have this characteristic abundant, lacy eosinophilic cytoplasm.
Eosinophilic cytoplasm. Okay, break that down. What does that mean visually? Does it just look different, or is there something more to it?
It means they stain very pink, a really distinct pinkish look compared to typical thyroid cells. And that pink staining isn't just, a visual quirk, it's a clue. It's because they are absolutely packed with enlarged mitochondria, the cell's power generators.
Ah, okay.
And that hints at these unique energy pathways driving this cancer. It's a really fundamental difference from other thyroid tumors.
So their look points to their biology. And Hurthle cell carcinoma, HCC, it takes that unique cell and turns into something pretty aggressive.
Exactly. ATC is rare, maybe only 3–4% of all thyroid cancers. But yeah, despite being rare, it's generally more aggressive than other differentiated thyroid carcinomas. It has a higher tendency for local invasion, growing into nearby tissues. It's more likely to spread to lymph nodes in the neck and even metastasize distantly, places like the lung, bone, sometimes even the brain,
Wow.
which unfortunately often means a poorer prognosis compared to patients with other differentiated thyroid cancers.
Given how aggressive it can be, what are the typical first signs? What might someone notice?
The most common thing is just a lump in the neck, usually just below the Adam's apple. That's the
Mhm.
classic sign. Less often, people might have pain in the neck or throat, maybe some hoarseness or voice changes, shortness of breath, difficulty swallowing. But those usually happen if the tumor gets quite large and starts pressing on things like the windpipe or the esophagus.
Okay. It definitely sounds like a serious condition. And you mentioned the diagnosis itself can be a real challenge. Let's get into that. Why is HCC so tricky to pin down?
That's a really, really important point. The key is its microscopic behavior. You see,
Hmm.
unlike a lot of cancers where you can get a definitive diagnosis from a needle biopsy,
Right, FNA.
exactly, the fine needle aspiration. With HTC, that often doesn't work. Pathologists need to see more than just what the cells look like. They need to see how they're behaving. Specifically, have they invaded the capsule around the thyroid or nearby blood vessels?
So that standard FNA biopsy isn't enough. That seems odd, given how common it is for thyroid nodules.
It does, right. But for Hurthle cell lesions, FNA results often come back as indeterminate, basically inconclusive.
Yeah.
And even the newer molecular or genetic tests they sometimes run on those biopsy samples, they haven't performed that well in reliably identifying HCC either.
Huh.
So what that means practically is that the definitive diagnosis usually requires surgery. You have to actually remove the nodule to do a full histological analysis, get the whole picture.
And once it's out, then how do they confirm malignancy? What's the telltale sign?
It's the invasion that's the key.
Yeah.
The presence of either capsular invasion breaking through the thyroid's outer layer or vascular invasion getting into blood vessels. That's what confirms it's carcinoma, not just a benign adenoma. And then they classify it further. Is it minimally invasive, encapsulated, angioinvasive, maybe with just a little vascular invasion, or extensive, or is it widely invasive?
And those distinctions matter a lot for prognosis.
Oh, absolutely. They're crucial because they tell us how aggressive the cancer is likely to be. A widely invasive tumor, for instance, that's linked to a much higher mortality rate. So the treatment strategy really depends on that finding.
You mentioned earlier that just seeing a lot of Hurthle cells in a biopsy might suggest higher risk, but it's not cancer itself.
Hmm.
So clinicians are sort of managing expectations until surgery confirms things.
Precisely. You might see a biopsy report heavy on Hurthle cells, which can suggest a higher risk, even in categories usually considered benign. But just having Hurthle cells present doesn't automatically mean cancer. It's really those invasive features seen after surgery that make the definitive distinction between a benign Hurthle cell adenoma and carcinoma. It's a real diagnostic maze.
Okay, so once you navigate that maze and HCC is confirmed, what's the treatment plan look like? I'm guessing surgery is front and center.
You got it. Surgery is the absolute mainstay. Now, for the less aggressive types like minimally invasive tumors or even benign adenomas, maybe a thyroid lobectomy, just taking out half the thyroid is enough. But for the more aggressive forms or non-minimally invasive HCC, it's usually a total thyroidectomy, removing the whole gland.
The whole thing.
Yep. And often they'll remove surrounding lymph nodes too, because like I said, maybe up to 20% of cases already have spread to the lymph nodes when they're diagnosed. And the surgeon's expertise here is just paramount. Getting a complete curative first surgery, that can really make a huge difference.
Okay, surgery first. What about radioactive iodine, RAI? That's so common for other thyroid cancers. Does it work as well for HCC?
That's a really key question. And honestly, the role of RAI in HCC has been, well, controversial.
Controversial. How
Yeah.
so?
Well, while it's standard practice after thyroidectomy for many other thyroid cancers, HCC cells are generally considered less avid for iodine. They just don't soak it up as well. So whether it actually improves cancer-specific survival or helps much in cases of recurrence or metastasis, that's often debated. It's questionable.
But some studies show a benefit.
Some large population studies, yeah, like from the SEER database, they suggest RAI therapy is associated with better overall survival for HCC patients. But whether that's direct cancer control or other factors, it's not entirely clear-cut like it is for, say, papillary thyroid cancer.
So the takeaway is, unlike other thyroid cancers where RAI is almost a given, for HCC it's more of a case-by-case discussion, maybe less effective overall, really underscores the need for that personalized approach.
Exactly right. REI might still be considered, but its effectiveness really varies. It just highlights how crucial it is to tailor the treatment plan to the individual patient and their specific tumor characteristics.
Okay, let's pivot a bit and dive into the science, the cutting-edge stuff. How are genetics, the molecular details, factoring into Hurthle cell carcinoma?
This is where it gets really interesting, actually. HCC has a unique molecular story, a unique pathogenesis that really sets it apart from other thyroid tumors derived from those follicular cells. For instance, many other thyroid cancers have common driver mutations, things like BRAF or RAS mutations. You don't see those nearly as often in HCC. It has a low frequency of those typical culprits.
So it's driven by something different, another set of genetic glitches.
Precisely. A really defining feature is this buildup of abnormal mitochondria. Remember those pink staining power generators?
Yeah.
Well, they're often structurally abnormal, and we see frequent mutations in the mitochondrial DNA itself, particularly in genes that code for parts of the electron transport chain, complex I especially. That's critical for energy production. And these mutations aren't just random. They're often found in a very high fraction of the mitochondrial DNA copies in the tumor cells. That suggests they're being positively selected for, that they're actually helping the tumor grow. It's like the cancer is hijacking its own energy system.
Wow. Okay, so fundamental changes in the cell's energy factories. Are there bigger genetic changes too, like whole chromosomes involved?
Yes, absolutely. Another hallmark is widespread chromosomal loss. Huge chunks of chromosomes, sometimes even entire chromosomes, just go missing. This often leads to what's called a near-haploid state, where the tumor cells have roughly half the normal amount of genetic material for many chromosomes.
Near-haploid? That sounds drastic.
It is. While some specific chromosomes, like 5, 7, 12, and 20, tend to be kept or even duplicated, these widespread losses are really characteristic of HCC. And they seem to correlate with how aggressive the tumor is, with progression and recurrence. This unique genetic landscape really shapes the tumor's behavior and how it might respond or not respond to therapy.
Okay. Given that aggressive nature and this really unique complex genetic picture, how do you manage HCC when it comes back or spreads? Recurrent or metastatic disease must be incredibly tough.
Yeah, stepping back to the clinical picture, recurrent or metastatic HCC is a major challenge. Patients might go through various systemic therapies, maybe molecularly targeted drugs, often in clinical trials. But finding treatments that consistently improve overall survival, that's still an ongoing quest. It's a very active area of research trying to find better options.
Can you give an example? How might these targeted therapies work, or maybe not work, even when we know some of the genetics involved?
Okay, let's consider a sort of composite case. Maybe a patient has tried multiple targeted drugs, everolimus, sorafenib, nidenib, lenvatinib. Lenvatinib, which hits multiple targets, has shown some promise. There have been partial responses in patients with refractory thyroid cancer, including HCC. I recall one patient in a study had a partial response for over a year, which is significant.
Okay, so some hope there.
Some hope, yes, but then other drugs, like sorafenib, might just cause too many side effects, intolerable toxicities. And this brings us back to precision oncology.
Mm.
You could do whole genome sequencing on a metastasis and find new mutations that weren't there initially. Maybe something like a TSC1 mutation pops up.
Okay.
Now, theoretically, TSC1 mutations could make the tumor sensitive to mTOR inhibitors like everolimus, so you might try that. But here's the complexity. Even if you find something potentially targetable, or maybe find that a common cancer gene like EGFR is normal or wild type, it doesn't guarantee success. For instance, drugs targeting EGFR, like panitumumab, which work in some other cancers, they were found to be pretty ineffective in HCC cell lines.
Why is that?
Possibly because other strong growth pathways, like the AKT pathway, are just constantly switched on in HCC, sort of overriding the effect of the EGFR blocker. It really highlights that just knowing the status of one or two genes often isn't enough in HCC's unique genetic context. It's not always a simple lock and key situation.
That makes sense. It's a much more complicated picture. So, for someone who's been through treatment for HCC, what does the long term look like? What kind of follow-up and vigilance is needed?
Long-term follow-up is absolutely crucial and highly encouraged. It's typically managed by an endocrinologist who really knows HCC. And it's usually a team effort. Surgeons, radiologists, oncologists, endocrinologists working together. Because again, it's not one size fits all. The main goals are, one, making sure thyroid hormone levels are right, since the thyroid is usually gone or partially gone. Two, detecting any residual disease that maybe wasn't completely removed initially. And three, catching any recurrence as early as possible.
What are the key tools for that monitoring?
Regular checkups, definitely. Often every 6 months at first. That includes a physical exam, feeling the neck and neck ultrasounds, very important. And blood tests are critical, especially monitoring TSH, thyroid stimulating hormone. Doctors will aim to keep TSH suppressed, the level depending on the patient's recurrence risk. And then there's thyroglobulin.
Thyroglobulin, that's the cancer marker, right? How well does that work for HCC?
Yes, for most HCC patients, after a total thyroidectomy, thyroglobulin is a very effective cancer marker. If the whole thyroid is gone, thyroglobulin should be undetectable. So if it becomes detectable or if the level starts rising, that suggests thyroid cells, either normal remnants or cancerous ones, are still present or growing back.
But there's a catch.
There is. If the patient develops anti-thyroglobulin antibodies, which can happen, then the thyroglobulin test becomes unreliable. You can't trust the number. In those cases, doctors have to rely much more heavily on imaging and clinical follow-up.
Okay, and speaking of imaging, beyond the regular ultrasounds, what about things like CT or PE scans? When do those come into play?
Right, depending on the initial risk assessment and how the thyroglobulin is trending, or if it's unreliable because of antibodies, other imaging is definitely used. CT scans of the neck and chest are common. PD-CT scans can be particularly useful. They look for metabolically active cells, which cancer cells often are. So PD scans are often used if HCC looks aggressive or there's suspicion of distant spread. And MRI scans might be used too, especially for looking closely at the brain, spinal column, or bones if there's concern about involvement in those areas.
Wow, that was a truly comprehensive deep dive. It's incredibly clear just how complex Hurthle cell carcinoma is. Even though it's rare, its unique biology and those diagnostic hurdles demand such a specialized, in-depth approach.
Absolutely. And if we connect this to the bigger picture, the ongoing research into the genetics, the molecular basis of HCC is just so vital. Really understanding these unique pathways, that's where the key lies. It's what will hopefully lead to developing more targeted, more effective therapies for patients facing this really challenging disease.
And what does this all mean for you listening in? I think it really underscores the incredible complexity we find even within a single type of cancer. It highlights the constant progress in personalized medicine, trying to tailor treatments, and it encourages us all to keep asking, what more can we learn about how our bodies work, especially when things go wrong, and how can we use that knowledge to help people? And as we wrap up this deep dive, just one more reminder about our sponsor, Stonefly. They're focused on robust data protection. Be sure to check out their latest offering, a 100 TB immutable and air-gapped SSO NAS, and it's just $8,995. That's 100 terabytes, immutable meaning the data can't be altered, and air-gapped for extra security, all for under $9,000. It's an incredible solution if you have critical data needs. Check them out at stonefly.com. We really hope this deep dive gave you some valuable insights today. Join us next time for another journey into being well-informed quickly and thoroughly.